right, sounds good. Thank you, Dr. Weiss. So first up, we have Dr. Mark Harrah. So Dr. Jara graduated first in his class from Universidad Nacional de Asunción Facultad de Ciencias Médicas in San Lorenzo, Paraguay. He then completed his training in internal medicine at the University of Buffalo, followed by a fellowship in endocrinology, diabetes, and metabolism here at the University of Miami Jackson Memorial Hospital. He then completed an additional fellowship in oncologic endocrinology at MD Anderson in Texas. Dr. Harrah is an assistant professor of clinical medicine here at the University of Miami. He has multiple peer-reviewed publications, primarily in the field of thyroid diseases, with a special focus on thyroid malignancies. With that said, I'll turn it over to you, Dr. Harrah, for your presentation entitled Updates in Medullary Thyroid Carcinoma.
Thank you so much, Dr. Flowers, and it's a pleasure to be here. Thanks for the invitation. And let me share my screen and let me know if you can see it. Okay. So I have no disclosures. The objectives of this lecture are mainly based on to identify the most important mutations responsible for medullary thyroid carcinoma, to understand the current ATA risk categories for hereditary carcinomas, and also evaluate the current therapeutic options in MTC, with a special focus on systemic therapy. It is estimated that 45,000 men and women in the United States will be diagnosed at some point with thyroid cancer this year. When we look at thyroid cancers, the clinical presentation and the classifications are based on the cell of origin, and with cancer originating from epithelial like follicular cells, and these are typical for the differentiated thyroid carcinomas. We can see the classical PTC, that is the most common type of cancer, follicular thyroid carcinoma, and a variant of these, the Hurdle cell carcinomas. Also less differentiated carcinomas as poorly differentiated and undifferentiated carcinomas, like the anaplastic carcinoma. These represent 90% of the thyroid cancers. And they actually go through as an indolent malignancy with 80 or 90% of the people usually surviving in this disease for 10 years. Now, different group of cells that can also produce tumors in the cell, in the thyroid. These are the C cells or parafollicular cells of the thyroid, and they actually lead to medullary carcinomas. These represent about 3 to 5% of these cancers. I will start this presentation with a case, and we're going to go through this case through the presentation, and will guide us to the different changes and drugs the patient needs. So this is a 55-year-old woman who self-palpated a thyroid nodule in her lower neck. She went to her PCP for evaluation. The PCP ordered an ultrasound and noted thyroid nodules and an enlarged neck lymph nodes on the ultrasound. Reason why he ordered a final aspiration biopsy. The nodule in the left was 2.3 centimeter, and also in the left there was a cervical lymph node that was biopsy, and both came up as suspicious. One of them as suspicious for medullary, the other suspicious for PTC. And this can have actually happened. She underwent total thyroidectomy and bilateral neck dissection. The pathology showed a single focus of medullary carcinoma in the left lobe, no lymphovascular invasion, but there were positive margins and positive extrathecal extension. 2 of 33 of their lymph nodes were involved, and the largest focus of these lymph nodes was 2.5 centimeters. Post-surgically, the first calcitonin and CEA levels were detectable for CEA at 8.5 and undetectable for calcitonin. But we can see that after 6 months, calcitonin turns to be detectable, and there is an increase in CEA. Now, for the residents, it's important to make these points before we start, and so you can remember which are the most important mutations responsible for MTC. Is genomic testing important in these patients? And also, besides surgery, are there other therapeutic options in MTC that can help to improve their survival? So, in general, medullary carcinoma accounts for 2 to 5% of malignancies, as I said before. The calcitonin is a specific marker for the diseases produced by peripheral follicular cells, but we also use CEA that is not a specific marker, but is very useful tool to detect disease relapse and especially disease progression after primary treatment. Two important points we have to make is that distant metastases represent a very important prognostic factor in these patients, as the 5-year survival in people who has distant metastasis is only 38%. A difference with people who has only regional disease that have like more than 90% survival, and localized disease is almost 100%. Now, it's not easy to find early signs in thyroid cancer, in none of them actually, and there is no really difference in the nodules. Most of them is important for us, a physician, to do always a very good physical exam. And that includes not only the thyroid, but also a lymph node screening whenever we do physical exam, because sometimes these patients can early present with a mass in the neck, or with swelling in the neck, or swelling in their lymph nodes. It's important to remember that 70% of these patients with MTC who present with papillary thyroid nodules can have cervical metastasis already at diagnosis, and even 10% of these can have distant metastasis. Now, we can divide thyroid cancer in two types of medullary thyroid carcinomas. One is the group of hereditary carcinomas, represent 25% of them. These are usually germline mutations. These are germline mutations present in every cell of the body of the person, usually in younger patients, and they tend to be multicentric. These kind of tumors are usually associated with 3 syndromes that are MEN2A, MEN2B, and familiar medullary carcinomas. These syndromes actually are driven by specific mutations. As we can see in the lower left corner, you see that there is a relation between MEN2A and familiar medullary thyroid carcinoma when most of these mutations actually overlap. Also in MEN2B, the most common mutation is the M19T. The survival is a lot better in the patients with MEN2A compared to patients with MEN2B, and that has to do a lot with the type of mutation. Now, sporadic carcinomas are somatic mutations usually, and these mutations are specifically in the tumor. These represent most of the medullary carcinomas, approximately 75%. We are found usually in older patients as the usual thyroid cancer, and they to be usually unilateral and solitary. Other important point is not all the cancers are driven by RED, but there is between 15 and 30% of them that can be found to have HRAS, KRAS, and very, very rarely NRAS mutations. Now, the American Thyroid Association has risk categories for these thyroid cancers. And this has changed over time. And the last time in 2015, they divide these in 3 risk groups. The highest risk for the 918 mutation, and in these patients, actually, they undergo thyroidectomy in the first months of life in the year of life as a recommendation due to the aggressive clinical course of this tumor. And also, there are high risk for 634 and 883. These usually get thyroidectomy before age 5. And the rest of the RED mutations that we can in hereditary carcinomas are actually grouped all together in the moderate group that we can see in the lower left. And these actually have thyroidectomy around childhood or early adulthood, and they usually follow. The recommendations for screening for FIO in these patients start at 11 years of age with the highest risk, and for the moderate risk at 16 years of age. Now, it's important to point on a study done by Shepard in Annals of Surgical Oncology. This study actually showed that patients with hereditary medullary carcinoma that underwent age-appropriate thyroidectomy and had no disease recurrences. But comparing to another group of people who actually did not have thyroidectomy or they have thyroidectomy past the recommended age, they found that 42 of these patients actually has a recurrence. So this actually points the increasing importance of genomic testing to identify alteration in these patients, especially hereditary carcinomas, as the only curative treatment we have is actually surgery. This also provides a rationale for early genetic screening for hereditary carcinomas. And unfortunately, none of these recommendations are perfect, and 9% of these medullary carcinomas patients present primarily as a somatic mutation, but they might have actually a de novo germline mutation. So we can be losing these patients. Now, most of the thyroid cancers are actually driven by RED mutations. And we're going to spend a little time talking about the RED proto-oncogene. This is a tyrosine kinase transmembrane receptor. It has 3 different domains. The large extracellular domain is a cysteine rich region that we see here in the right upper corner. It has a transmembrane domain and an intracellular domain that is in yellow that is actually a tyrosine kinase domain that is required for phosphorylation and downstream signaling. The way these receptors are activated is by ligands called GDNF that actually form a heterodimer with red by joining co-receptor GFR alpha 1 to 4. When they all together actually join, they lead to autophosphorylation downstream and of the intracellular tyrosine kinase domain, leading to signaling pathway activation. These usually promote proliferation, survival, and migration of these cells. But we know that red is also an oncogene and is associated with growth and cancer in medullary thyroid carcinomas and other carcinomas. So the way these, so we also have mutations, and the mutations when they occur actually as an oncogene for medullary thyroid carcinomas occurred as red mutations. And these are via gain of function or missense mutations. And in some cases, we also have chromosomal rearrangements, and especially in PTC and small lung stem carcinomas. The red proto-oncogene usually drives 70% of medullary carcinomas. And in the somatic world, actually, 60% of the sporadic mutations harbor red mutations. And the most common mutation for somatic tumors are somatic mutations in sporadic carcinomas are the red M19T. I just put it in black so you remember this is for questions after the talk. So in Vivek Subhayat and MD Anderson did a very beautiful actually review and targeting red dependent cancers and JCO in the year 2020. He actually found that the frequency of somatic red mutations in MTC was M19T was 70.5%. That is very close to the number that was found before. Also, it's important to know that there are other mutations very typically found in hereditary carcinomas. The red 634 is the most common in MEN2A, and the M19T, as I talked before, for the MEN2B. Now, gene fusions, of course, are not very common in the adult population. They represent 10% of the cases, but it's very common in the pediatric population, where they represent 30%. The red fusions are also very prevalent in people who underwent radiation. It's important to know that when oncogenic red has this mutant red in the cell surface or through fusions inside the cell, as we can see here in the right lower corner, this basically has an ongoing signaling through red, producing tumor growth and proliferation. Now, after this small introduction about medullary carcinomas and the type of mutations, we continue a little bit with the case that we were talking before. We noticed before that the patient was having already detectable thyroglobulin. She underwent genetic testing that found a somatic red M1918 mutations. As expected, as we talked before, that this is the most common somatic mutation. And 2 years after her surgery, she was noted to have disease progression with elevation of the tumor markers. And we can see a very elevated CEA and calcitonin. This is actually a very ominous sign here because it talks about poor differentiation of the medullary carcinoma, as you can see a higher degree of CEA comparing to calcitonin. There was also a radiologic evaluation with a structural progression showing progressive disease in the liver, lung, and bones. So when we talk about treatment options in these patients who have progressive disease that are not amenable for surgery, we go to the world of systemic therapy. And in these patients, we have multi-kinase inhibitors. There are 4 different drugs that are currently approved at the FDA for medullary carcinomas. The first 2 that were approved around the year 2012-2013 were multi-kinase inhibitors pharmacological treatment were vandetanib and cabozantinib. Vandetanib is actually a once-a-day oral agent that selectively inhibits RED, VEGF alpha, and EGFR and EGFR. In cabozantinib, does not significantly inhibit EGFR. It does it with VEGF and also does with the hepatic growth factor receptor MET, as well as RED. The 2 trials that led to the approval of these drugs, and the first one was the CETA trial, and they used vandetanib 300 milligrams given to patients with progressive, actually with metastatic disease, medullary disease, versus placebo. The primary objective of this the test was to test progression-free survival. And just for the residents, progression-free survival means the time from the random assignment in the study to disease progression or death in these patients. The median duration of response of these patients were 22 months, and vandetanib showed actually a significant difference comparing to placebo, 30.4 months of progression-free survival comparing to the placebo. The rate of treatment discontinuation in these patients were low at 12%, and dose reduction was required only in 35% of the cases. Now, it is important to notice that we indeed can see that the patients were not a very severe condition and they were not in progressive disease. This was the design of the trial, and because the placebo has a 19.3 months progression-free survival. The other study is different because we can see in cabozantinib actually that the median progression-free survival was only 11.2 months comparing to 4 months in the placebo group, with an estimation duration of response of 14.6 months. Of course, these patients were more severe and actually in the organization of the study, they actually allow patients with progressive disease. So these studies are difficult to compare because these patients were actually more severely diseased comparing to patients in the vandetanib trial. This drug is more potent, has more VEGF inhibition, producing more secondary side effects. That's why we see a reduction in the dose in almost 80% of the patients, and holds and partial holds of medication in 65% of them, and even discontinuations in up to 16% of these patients. Now, the effectiveness of these drugs are importantly limited due to the toxicity. So the RET inhibition that we can see with these drugs is important and generate response in these patients, but cannot be long lasting, as most of these patients cannot tolerate the toxicity. So that inhibition is insufficient due to the decrease in the dose of these drugs. Also, we have found new mutations that actually develop resistance to these drugs. One of these is the RET-VO4 Gatekeeper mutation. This acts by blocking the ATP binding site of the drug to the RET gene. The most common side effects of these drugs are diarrhea and usually skin lesions. It is important to know that these drugs actually have a black box warning for QTc prolongation, so all these patients have to be followed with periodical EKGs to notice that. So going back to our patient, she was started on vandetanib initially with a partial response and a very good biochemical and structural response with decrease on the disease 10 weeks after starting treatment, and really good tolerability, like only grade 1 adverse events. And unfortunately, over time, the patient had progressive disease with increasing structural disease with hilar and abdominal lymphadenopathy. And we can notice here in the graph below how the disease at some point makes a jump, and we can see increase in the tumor markers. So at this point, the patient was started on at that time was the studies were undergoing for the 2 now approved RET inhibitors. So she was started in one of these RET inhibitors. So I'm going to talk about these 2 new RET inhibitors that are currently approved. The last approval was in December 2020 from carcinoma, and before that was selpercatinib or LOX-292, and at the beginning of 2020. Both are very potent and selective inhibitors. We can see that when we look at the chymons here in the right upper corner, how they are really localized in the RET location. We can see a little more of VEGF activity in pralsetinib here comparing to the RET, and also that can be seen when we look at the IC50. For the residents, IC50 is what we call the max inhibitory concentration. It is a measure of the potency of substances when you inhibit like a specific biological or biochemical function. So the higher the number, the lower the inhibition. So in this case, you see higher numbers for VEGFR2, for LOXO292 and BLU-667, and lower levels for vandetanib. That means they are more potent against VEGFR. Also, we can see here that selectivity that makes these drugs so good. against the wild type RED and M19T mutations, and the VO804 and Gatekeeper mutation that actually we can see why we have the resistance here when we look at the IC50 and very low IC50 number for LOXO and blue. Also, these drugs were approved in 2020, but not before getting preclinical studies. In xenograft models, and that was the initial place where these actually call attention from researchers. Selpercatinib was originally studied in xenograft models to compare it with other drugs, but that included cabozantinib, LOXO, and Abicol at that time. We can see in the vertical like the unbridled growth of the tumor without any resistance. But when we give LOXO, actually, it has a cross pan-RED inhibition with good response in the tumor size. This was also seen in autotropic brain models. Those are in RED fusions and CCD6 RED and fusion and tumors. And we can see here that in this model, there is a longer longevity in patients taking the LOXO 292 right in the back of the corner, comparing to the patients taking other kinase inhibitors. In this case, they use panatinib, and I'm comparing to the vehicle. These results actually caught attention of researchers and led to the development of the phase 1 and phase 2 trials that we know for these two drugs. And the first one is the Libretto-01 that led to the approval of selpercatinib. We're going to talk specifically of the medullary thyroid cancer in numbers or results, not of the lung and non-small cell carcinoma. This study was done to actually study these two tumors and the non-small cell carcinomas. In the medullary thyroid cancer data, there were patients who were randomized to the ones who received prior cabo and bandetinib and the ones who actually cabo and bandetinib naive, so people who never received medication before. The primary analysis said patients with RED mutation who received cabo and bandetinib, those were 55 patients, and these studies were actually published by Laurie Wirth from Mass General in the New England Journal of Medicine last year. The primary objective of this study was objective response rate. And for residents, again, objective response rate is the assessment of the tumor burden after a given treatment is given to the patient, especially usually in solid tumors, and is very important parameter to demonstrate efficacy of a treatment. And the second endpoint was progression-free survival and safety and duration of response. So when we see the data published in the New England Journal, we can see that the objective response rate in the patients previously treated with other multi-kinase inhibitors was 69%. And the patients not previously treated were 73%. And the patients who had RED fusion and papillary carcinomas was 79%. And when we look at best response, we can see that some patients actually had a complete response, with most of them getting partial or even stable disease with the treatment. Also, when we look at the waterfall plot, we can see that all the patients who got bandetinib, cabozantinib, or both bandetinib and cabozantinib, in the waterfall plot, we can see, and this also for residents, these are individual patients with different colors that we can see which drugs they received. And actually, we can see here that both were equally likely to be effective. It don't depend on which drug he received, and the patients received, and most of them exceeded the 30% cut for partial response. In the right side in graph, we can see that the previously treated patients that did not receive bandetinib or cabozantinib, they also got a great response with almost all of the patients, with except of one patient in the left upper corner here, that they have an excellent or at least some degree of tumor shrinkage showing response. Now, the other drug that was approved is praseltinib, or was blue 667. This drug was also divided in the same fashion, 2-to-1 with 400 milligrams of the drug, with patients having prior drug treatment with cabozantinib or bandetinib, or patients that did not have previous treatment. And we can see that the objective response rate of these patients was close to 60% in the ones who received the drugs or previous treatments before, and 74% objective response in the ones who actually did not receive. These results led to approval of both drugs in 2020. Now, safety profiles of these drugs, most of them produce grade 1 or 2 side effects. Those are tolerable side effects. Their effects are a lot limited comparing to what we have with multi-kinase inhibitors. And this is thanks to the selectivity, but of course, they're not devoid of side effects. And the ones that I want to point here are specifically what makes different pralsetinib from selpercatinib. And this is like a slightly higher toxicity in selpercatinib compared to a high bone marrow toxicity in pralsetinib. So we usually do chemo labs for these patients at 15 days and then every month at the beginning of at least 3 months to make sure that these patients don't develop any of these effects or grade 3 that we have to hold or decrease dose of the medication. In this case, the selpercatinib only have 30% reduction, 30% of the patients need a reduction, and only 2% of them discontinue the medication. Now, returning to our patient and who was on selpercatinib, actually, she got an excellent response to the treatment with decrease in structural disease and tumor markers. And we can see that beautiful response with the tumor markers after 30 months when unfortunately the patient progressed even with the medicine. And when the patient progressed, we saw that actually in the new tumor analysis that she developed a red GA10 solvent-front mutation. That is actually a new mechanism of resistance found in these drugs. This solvent-front mutation is actually—
1 minute, 1 minute, Mark.
Yeah, almost finishing. Actually produce resistance to the patients by not allowing to bind to the tyrosine kinase domain. So in general, for the future, we are having 2 drugs that are actually being studied. One is TPX-0646. That is a drug that is actually inhibits SRC and RET. That is actually for these patients who have the Gatekeeper mutation, and a new study that actually is undergoing now that has a purpose to understand how selpercatinib compared to Cabo and Vandi. This is something we didn't have before and will allow us actually to see what could be the correct sequence of treatment. And this is Liberto 531 that is actually undergoing now. So for conclusions, it is important to evaluate genomic testing and identify mutations in patients with NPC. The recently approved RET inhibitors have an excellent and durable response for RET mutations and RET fusions, and they're highly tolerable. And also it's important to know those mechanisms of resistance and to retest the tumors in case we see progression with these drugs. Thank you.
Thank you, Dr. Jara. That was a very thorough and erudite review of the latest information, really latest information on medullary thyroid cancer. You know, we sent you to MD Anderson for a year, and you de-differentiated from an endocrinologist into an oncologist. I'm going to think twice before we lose any more endocrinologists. No, I'm just joking. You really did a great job, and I'm glad that you're able to bring back the expertise along with our oncologists for the treatment of this very rare cancer. Let me just ask one quick question. So what happened to the rest of the family? Was anybody else screened? Did anybody else have mutations? What do you know about them?
Yes, she has a somatic mutation. That means it's a sporadic carcinoma. So being sporadic, and we don't expect the family members to actually have the mutation. This is actually present and in the person. And actually, you first do blood testing. That's for germline mutations. And in germline mutations, actually were negative for these patients. We didn't expect them to have it. But then when she was positive, it's actually the tumors in the tumor itself. And that's what we find, and we call it somatic.
Okay, thank you. Dr. Flowers.
All right, thank you so much, Dr. Harrah. So next, I have the honor of introducing our next speaker, Dr. Maria Carpintero. She began her medical training at the Universidad del Rosario in Bogota, Colombia. She then moved to Miami to complete her training in internal medicine, followed by rheumatology, both here at the University of Miami Jackson Memorial Hospital. Following her fellowship, she was hired as an assistant professor of clinical medicine and is currently focusing her research on treatment options to improve the lives of patients with systemic lupus erythematosus. Dr. Carpintero currently has extensive funding for her research, including from the Lupus Clinical Investigator Network Infrastructure Grant, and she is involved in several ongoing randomized controlled trials in various lupus therapies. Please give a warm welcome to Dr. Carpintero, and with that, I turn it over to you for your presentation entitled, What's Old and What's New in SLE.
Good afternoon, everyone. I hope everyone can see my screen. Okay, let me start playing this. Very honored to be here again with you. So these ones are my disclosures that Dr. Flowers was referring about. So I'm going to start my presentation with a clinical case. This is one of my patients in the clinic, and actually I follow her since I was a fellow. So she was diagnosed in lupus in 1995. She presented with, my lupus with fever. She was found with pancytopenia, skin disease, arthritis, and positive antibodies for ANA, double-stranded DNA, and low complement. She was treated with, different doses of steroids and hydroxychloroquine with good response. She did well over time, but in 2000, she had a severe flare, including fever with worsening anemia, pancytopenia, significant rash, worsening arthritis, and altered mental status. She was diagnosed with cerebritis. She needed treatment with IV steroids, cyclophosphamide for 6 months, and she was transitioned to azathioprine. She did well for quite some time, and she was able to taper her steroids on some of their immunosuppression. But in 2008, she started to have hypertension, lower extremity edema, and further workup showed that she had proteinuria. And she was diagnosed with lupus nephritis class 4, and at that time she was induced with steroids, again with cyclophosphamide, and then she was kept on remission with mycophenolate. She did well, and she did that well that she lost follow-up from us in the clinic. So she stopped all her immunosuppression for quite some time. And in 2016, she came to the hospital with worsening disease activity. She was found with significant pancytopenia, fevers, significant arthritis, skin rash. She required steroids for disease control. And unfortunately, since then, she has kept an active disease with multiple flares that continue to occur despite the immunosuppression and the different dose of steroids. So during this time, she was tried all these immunosuppressants with either side effects, with some type of allergy or some intolerance to the medication. As you can see, some of these medications have been used off-label in her case. So I saw her relatively recently in her clinic. So she initially went to her primary care physician because she wasn't feeling well. She was complaining of worsening skin rash, similar to what you see in the picture that is consistent with subacute cutaneous lupus. She also presented with multiple tender and swollen joints. Further disease activity done by her PCP showing a white blood cell count of 2.5 with lymphopenia, and increased double-stranded DNA and low complement. At the time, her primary care physician increased her steroids from 10 milligrams, that is her baseline dose, to 30 milligrams, and as well kept her on her medications that she's currently taking, methotrexate and hydroxychloroquine. At that time, she discussed with, her primary care physician the use of steroids because she already has multiple complications. She has Cushing-Gott phases. She also had a vascular necrosis requiring a right hip replacement in 2009, and she has a low bone mineral density for her age. So she's not really happy with the use of steroids. So she asked her PCP why she's still taking the hydroxychloroquine. She's been taking this medication for quite some time, and she's still sick. She's still having flare-ups of her SLE requiring, the use of steroids, and, what is she going to do from now on to control her disease. So now to answer her questions, so we're going to talk about the hydroxychloroquine. So hydroxychloroquine is one of the antimalarials that we use for SLE. The exact mechanism of action, we don't know it. We believe it works through lysosomes, so it accumulates in the intracellular lysosomes, decreasing the DNA binding with the toll receptors, especially TLR9 and TLR7, blocking the stimulation of them, and decreases some inflammatory cytokines like IL-6, IL-1, TNF, and interferons. It's one of the few medications that the FDA approved for SLE, and we use it dose for body weight, 5 milligrams per kilogram, no more than 400 milligrams per day. Is used most in patients that have cutaneous manifestations, arthritis, serositis, and fatigue. Hydroxychloroquine has multiple groups through the last 25 years has found that has other adding benefits in patients with lupus. So it's safe during pregnancy and lactation, and decreases the chances of neonatal lupus in patients that are SSA positive. Lower the glycosylated hemoglobin levels in patients that are diabetic, decreasing the insulin degradation. Also, is the only medication that has shown that in patients with lupus reduces the flare rate in half, reduces the organ damage, has an decrease in the platelet aggregation, so it has reduced the thrombosis mostly in patients with antiphospholipid syndrome, also has anti-hyperlipidemic effects, so it has some good effect on lipids, and triples the mycophenolate response in patients with that takes the medication or in lupus nephritis, and also has an added effect in patients that take methotrexate and improves survival overall. Other groups have a study what happened on those patients that have been taking, hydroxychloroquine, and and they decide to stop the medication. So Papa Christos group in Toronto did a study with 1,400 patients, and they stopped the hydroxychloroquine in patients that have been on remission for at least a year or so. And what they see as the patients that continue taking the hydroxychloroquine, they did better in terms of outcomes compared with those ones with that did stop the medication. Also, they decided to look at the patients that stopped the hydroxychloroquine and compare those ones that stopped abruptly the medication compared with those ones that were withdrawal. They did a taper of the hydroxychloroquine, and the patients that they did a gradual decrease of the hydroxychloroquine and were on remission. They did better compared with those ones that did not. Also, the group of Almeida in Brazil, they study patients with lupus with active disease, and they divided the patients between those ones who stopped the hydroxychloroquine and those ones that continue the medication. The patients, obviously, that stop hydroxychloroquine did a lot better, and they have poorer outcomes and more times to flare compared with those ones that continue the medication. And they saw that patients that were taking high dose steroids or have failed multiple immunosuppressants did worse than the patients that did not have these findings. So except in the setting of toxicity or side effects, reducing or stopping therapy in patients with active disease is not advised. So in this case, to our patient, we advise her that even though she still has active disease and has not perceived the benefits of hydroxychloroquine, stopping the medication will be not the best option for her at this time. So now in terms of what are we going to do next? So the next step with her is induce and maintain remission to prevent organ damage. Unfortunately, with lupus, we don't have many base recommendations, and most of the treatment is based on case reports on controlled trials. We only have one FDA-approved medication based on randomized controlled trials because most of our trials have failed or not meet the endpoints. The issue with lupus is, or disease is very heterogeneous, and the endpoints are difficult to achieve, and we have multiple disease activity measures with different goals, and some of these ones we don't use it on clinical practice. So to avoid this type of confusion and have a better outcome on clinical trials, we're using now the concept between low lupus disease activity versus remission. So Ugarte and Moran, so they have done multiple studies with around 1,000 patients. So they divided the patients that have active disease with remission and compared those patients with active disease. They stratified with moderate to severe disease and with low disease based on multiple scales that we use to measure disease activity. So when they did the comparison between the patients on remission with low disease activity, they have less damage accrual compared with patients with active disease. And, the conclusion is that low lupus disease activity, it could be set as an endpoint because also, has, it will show that it's the effects of low lupus disease activity is a reasonable target to achieve in those patients that you can't really get into a full remission. Okay, so this is the current therapies that we have for lupus. In the left side, you're gonna see the only 4 FDA approved, and belimumab is the only one approved based on randomized controlled trials. The other standard of care are, based on uncontrolled studies, and we haven't had much advanced in the last 10 years. So most of the patients with lupus have high interferon signature. So most of in vivo studies have shown the serum levels of antiferon are elevated in patients as well. Multiple genetic studies have shown that they have lupus patients has a significant interferon signature. And based on these findings, we have anifrolumab, that is an IgG1 kappa monoclonal antibody that binds to the type 1 interferon receptor. It reduces the levels of the surface receptors and decreases the amount of interferon in the patient, as well blocks the plasma cell differentiation. FDA approved these medications for the treatment of active SLE patients with moderate to severe disease who are receiving a standard of care last August. And it was the first medication second FDA approved medication from randomized controlled trials, and the second in the last 10-year span. The approval of this medication was based on 3 trials, two phase 2B, the MUSE trial, and 2 randomized controlled trials, the TULIP-1 and TULIP-2. The TULIP, it stands for treatment on controlled lupus via interferon pathway. So the subjects enrolled to these studies, so they're patients, adults with lupus, according with ACR and SLEEK criteria, with moderate disease. So moderate disease is more than 6. Severe disease is more than 10 in the SLEDA score. And we wanted to have patients to have clinical domains, not only abnormal laboratory data, but also some clinical findings as well. BILAC is another measure of disease activity that checks for 98 items in 9 organ domains, and these patients should have some active disease, that means A or B. As well, a confirmatory test for a seropositive disease, positive antibodies. So these studies were a 52-week treatment period. You have your 1-to-1 ratio in terms of randomization to receive the agent or the placebo. The endpoints were the SRI-4, that is a composed measure of active disease activity, and the BICLA, that are also another composed measure for disease activity. Other endpoints that were checked, the SLEDA-2K, changes from physician global assessment, patient-reported outcomes, as well the time to the first time to flare, the change in joint count, the CLASI, that is the skin disease score, changes on biomarkers. Okay, so all these patients in this study that had more than 10 milligrams of prednisone at the moment of enrollment, they had a mandatory steroid taper with the goal to have less than 7.5 milligrams of steroids at the end of the study. So the results of the study, so the first randomized control trial did not meet the primary endpoint, but when they did a postdoc analysis, they showed some improvement in the steroid use. So patients were able to have a steroid taper with decreased the time to flare, as well improvement in cutaneous disease activity, and the BICLA response, that is another composed disease activity that measures more improvement in terms of time rather than being on remission. And the TULIP-2 study show improvement on disease activity in the primary endpoint. And this is the pool data of the studies. Okay, so what things we saw with the results of the medication? So anifrolumab was associated with decrease of the use of steroids through the study. So patients that were taking high doses of steroids were able to taper with a goal of less than 7.5, favoring twofold time and with no decrease in the time to flare. Also, the patients that were able to taper the steroids showed sustained reduction of the dose through the study. So they didn't have to, be using rescue steroids. and also the time to flare. So these patients showed improvement in terms of disease activity and sustained disease activity over time. And this was seen especially in patients that were taking more than 15 milligrams of prednisone at the start to the study. Okay, so in terms of what other good findings this study show, so looking at different domains and looking at the improvement in disease activity using the BILAG and the SLEDA 2K, it was on trend towards improvement of certain disease activity, so mostly in the mucocutaneous and musculoskeletal disease. And in the musculoskeletal disease, the improvement was seen mostly in patients that had moderate to severe arthritis. So they have more than 10 swollen or joint counts. Other of the domains that we see, like the immunological, it was a trend in improvement in complements, as well as decrease in lower stranger DNA. In the hematological, some improvement in thrombocytopenia and pancytopenia. But again, the numbers are too low in terms of the number of patients. So we have to look with caution some of these numbers. Also, patients with severe lupus CNS lupus involvement were excluded from the study, as well as patients with lupus nephritis were excluded from the study. So patients that have a creatinine more than 2 and a protein creatinine ratio more than 3.5, they were excluded from the study. Okay, so the major finding that the study found was improvement in mucocutaneous disease. The skin response was measured by CLASI, that's disease activity tool that we use, and we check the how many areas of the body the lupus rash is affecting and how severe the rash is. What we can see in this graph is the separation between the treatment group versus the patients in placebo, and the response was as early as week number 8, and it was sustained through the studies. Also, the anifrolumab showed that patients have not also improvement in clinical findings, but also in patient-reported outcomes. So patients using the fatigue scale, the FACIT fatigue scale, and SF-36 for mental and physical well health, patients have significant improvement, and a postdoc analysis also has shown that some of these patients have decreased the number of visits to the emergency room, urgent care, or to walk-in clinics related to lupus flares. So the adverse events, the safety was consistent with other clinical trials and across the arms. The most common was like upper respiratory infections, nasopharyngitis, infusions reactions. It was only 2 deaths through the study, both patients receiving the agent, and both patients died from a pneumonia. And the other adverse effects of interest that we saw, it was a trend in increase of herpes zoster infections. So the pooled data from the 2 trials show an increase of herpes zoster infections, mostly, as you can see in the numbers, is dose related. It was not severe enough to exclude the patients from the trials, but the patients where the medication was held, where they were treated. Most of the patients had cutaneous involvement, and only a minority of the patient had more than 3 dermatome areas affected. And this data is consistent with the mechanism of action of anifrolumab. And no deaths were attributed to herpes zoster through the trial either. So to a discussion, so anifrolumab has the potential to be a new treatment for patients with moderate to severe SLE who had failed a standard of care and who had been able to taper steroids. Unfortunately, we don't have much data in lupus nephritis. It's one of the main manifestations on, patients with lupus. We don't have any data on patients with severe CNS disease or pediatric patients. And, we don't have any long-term safety data in lupus patients. With this medication, we have to be cautioned, regarding their herpes zoster, infections. We don't know how effective is going to be the vaccination for herpes on these patients, or how effective is going to be, antiviral treatment in patients taking anifrolumab that have, a herpes zoster infections. As the data still, we have, not enough data. So the conclusion for today, so hydroxychloroquine has a central role in the management with lupus, and all patients with SLE should be on the medication unless the patient have a side effect or in the setting of toxicity. The cessation of antimalarial therapy can be feasible in patients with long-standing lupus in long-standing remission while on with the watch of a rheumatologist. In the last decade, in terms of treatment with lupus, we have the development of multiple targeted therapies that, that is giving them some potential for therapeutic targets for patients. With lupus, we still have a lot of unknowns and things for improvement, but with anifrolumab, we have a new promising therapeutic approach for patients that still have been not able to respond to recurrent available therapies. So we do have a, answer for our patient in the sense that we do have a possible new therapeutic option available for her, and hopefully something that is going to be able to decrease her amount of steroids and give some improvement for her quality of life. Thank you.
Thank you, Dr. Carpintero, for a really nice case presentation and review. Learned a lot about treatment of lupus and what to look for. So thank you. This presentation is open for discussion. We have a few minutes. In the meantime, if you could please post the link for the CME. I don't see it on the chat, Darren. Okay, well, thank you all very much for participating in today's Grand Rounds. We'll continue next week. Wishing everybody a good and safe and healthy week. And Darian, we're waiting for you to upload the upload. If not, we'll be sure that Darian sends everybody a copy of the link through their email, so you can sign off and go to your next, there it is. Okay, everyone. Thank you.
Thank you.
4, 1, 3,